Welcome to the #1 spot health and wellness practitioners go to double their current income and turn their 10-hour work day into a 10-hour work week. Join us as we dive into the tips, tools, and tech you need to create a life and practice on your own terms. More freedom, flexibility, fulfillment, and of course, funds. It's time to build your online practice. And I'm your host, Michelle Rogers, also known as the Wealthy Woman. Be sure to subscribe for your weekly dose of education, inspiration, and action. Let's get started. I want to introduce you to Dr. Dicken Weatherby. Welcome, welcome, welcome. This talk or this session is called Functional Blood Analysis, Uncovering Hidden Health Insights. And so Dr. Weatherby, he's an MD, a world-leading expert in functional blood chemistry analysis. For sure, he's why I do what I do. He graduated from the National College of Naturopathic Medicine, now called the National University of Natural Medicine in Portland, Oregon in 1998. Old school naturopath.
It's funny to think that, God, it's just like yesterday since I left. 23 years later, whatever it is, it's like, okay. Yeah, I'm one of those people now.
Heck yeah, you're like one of our elders. It's good. It's good.
Oh my gosh, yeah, well, that's pretty cool.
Maybe I shouldn't say that.
No, that's good. I love it. Yeah.
Cool. His best-selling book, Blood Chemistry and CBC Analysis, Clinical Laboratory Testing from a Functional Perspective, has become a seminal text on the functional analysis of blood test results. Dr. Weatherby is the founder, president, and CEO of OptimalDx and the ODX Academy, and the groundbreaking blood chemistry software program at OptimalDx.com makes it easier for healthcare practitioners to extract functional and nutritional information from their patients' or clients' blood tests and to give them a powerful analytical reporting tool to use to bring their patients back to optimal health. Dr. Weatherby teaches his FBCA mastery training and certification program through the ODX Academy, and I couldn't recommend it more. It's a fantastic, fantastic program. Yeah, for sure.
Cool, thank you.
So welcome.
Thank you so much. Yeah.
I have a couple kind of like icebreaker questions I've been asking everybody. And they are, one, what have been kind of the biggest struggles working virtually? Because I know you see clients like virtually and you're familiar with like the virtual space. But what are like the main struggles that you've run into? And also what are some of the best kind of perks of working in the virtual space?
Well, I'm going to let you in on a little bit of a clue. I don't see a lot of clients personally. It's like I'm 100% into the research and work that I do at ODX. Doesn't mean that I don't consult with my clients are health coaches, practitioners, naturopaths.
Yeah.
Same. It's like
mostly.
It's funny. You sent that question to me, and I'm like, I've been virtual for 20 years. It's like I've never had not since I stopped my clinic, which was back in 2005. So it's like I've been a long time since I've been sort of out of the clinic side. But I will say, I've talked to a lot of practitioners. When the pandemic hit around March, April of 2020, we got a flood of phone calls going. I don't know what to do. My practice is so I sat down with all of them. I said, listen. What's going to happen now is that we're transitioning. We're transitioning into an online consultation base, and you are primed for that. It's like, with not, if you're using the software, great, because it's like you now can do Zoom calls just like we're doing and sharing your screen, and you can actually walk through a blood report and show the meanings that you're extracting from it, putting together those individualized treatment programs. So you're actually poised to really take advantage of it in a way I think that most, maybe allopathic physicians that are stuck in hospitals, they were transitioning through to, major COVID relief type stuff. So I think this is a great time to be a practitioner. I really do. I think we've got so many tools and so many things at our disposal. I will say, however, I think the one thing that we're missing out on is getting our hands on people, actually that physical experience, because the body transmits information verbally, also just through the bodily fluids that we collect. But also, I think, that when you're sitting opposite a patient, there's nonverbal cues that you're picking up, which, you can pick up to a certain extent through this medium, but Yeah, so I think that's a bit of the downside. Is like, you're not able to like look at that skin. I mean, I actually had a virtual physical exam with the physician once. He was like, "Okay, now come up to the camera," and it's like, "Okay, this is ridiculous."
Yeah. That's like, and that's the thing. Like when I'm talking to my practitioners, it's like that's what I love is like the collaboration you get to create and the networking you get to create with other practitioners who are local, who can see your clients, like people that you trust. And so it's like they can give you that feedback and be like, "This was the texture, this was the physical exam, this is what I found," or doing visceral manipulation or craniosacral or like any of that hands-on stuff is like if you can build that network, like then you've got, I feel like, the best of both worlds. And I feel like your clients and patients have the best of both worlds that way too. Yeah.
One of the things that I always talk about is that, blood is one medium of exchange of information, and you must have others. It's like you've got to listen, you've got to be able to see, you've got to be able to measure other parameters. It's a little bit like that old, I think it's probably a Hindu image of like all of these blind people touching parts of an elephant. Now the elephant is this long thing, and it's like, well, don't be like that. It's like, collect as much. I always say, cast your diagnostic net as wide as possible, so that if it looks like it, smells like it, tastes like it, it probably is it. If not, just use it as information. Allow it to flow through you, and your brain will start to make associations of things. That's why I love this work. And the blood is such an incredible vehicle for communication of information, but we still have to marry it up with what's our patient telling us, what are some of the other information that we can gather.
Totally. I love that you said that, because a lot of times I tell my practitioners, it's like, if you're just looking at one test or one biomarker or whatever, it's almost like trying to appreciate a painting or a mural through a pinhole, right?
Yeah,
and it's like having that macroscopic view and really being able to see like how everything fits together and cross-referencing when, applicable, and all of that, taking your client's symptoms and all of that into account is absolutely needed. That's what holistic care is, right? And it's just like, yeah, it's perfect. And blood has been, like I said, it was like the first vehicle for me to get into functional labs and functional lab analysis. And it's like foundational. Like I couldn't do the work I'm doing without this. So we're going to dive into some really cool stuff. And I think you guys are going to be like excited about this. So let's go ahead and chat a bit about you and like how you initially got involved in blood chemistry analysis.
Well, it's funny because I was raised, my mum's a chiropractor in England, and she was into holistic medicine long before I was born in the 60s. So we were raised vegetarian, we were raised with homeopathy, no vaccinations. When we had earaches, she would put olive oil and mullein and garlic. And if we had coughs and colds, she'd be making poultices. And so for me, it was like, natural medicine was just sort of what I grew up with. And so when I heard about naturopathic medicine and National College, I was like, okay, this is what I want to do. So I started my journey in 94 when I started school in September 94. And it was kind of interesting because we were having like philosophy classes with Dr. Jared Zapp. I don't know if you know Jared Zapp.
Yes,
right? He's just like the godfather of philosophy. So one night we would have these classes with him, and it would just like be blowing my brain open. And then we'd go into lab science classes, and it was just like, wait, there's a disconnect here between what we're learning around this sort of functional concept, naturopathic concept, and then we were going straight into pathology class, and we were looking at these blood biomarkers from a pathological perspective. And I was like, wait, there must be something different here. So I actually, I remember it's like I went to listen to Dr. Harry Eidner, who was from Biotics Research. And he did a presentation at a small little hotel in the airport, around the airport in Portland, Oregon. And he wasn't like, lecturing with PowerPoint. He just basically drew up a stool, sat down, opened the manual and said, I'm just on page 103. And it was just the information that was coming off this guy's textbook was just blowing me away. And it was all about how do we look below the surface? How do we see these numbers that we all have available to us, and realizing that there's hidden information here? And you have to train yourself to understand what that is. So yeah, that was kind of my first. So that was probably April, probably about this time, 96. And then I started doing it all, in clinic, and I did my senior thesis on blood chemistry analysis. And then when I got out into practice, I was lucky enough to work with a DCND who graduated from National in 74 or something. He was an old-time doc. And he basically taught me everything he knew about lab testing. And I ran his lab for a year and a half. So it was so I was in the right place at the right time. And I'm a sponge. I've been writing textbooks and, I'm constantly writing stuff. So I basically tried to synthesize all of this information I was gathering and put it into my book. And then people wanted me to teach seminars. And so I started teaching seminars. It just blew up finally into software. So it's just been, since 96, so a long time.
So cool. So cool. Yeah. I love that. It's like when things happen like that, it's like the right doors open at the right time. And it's just like, you feel that flow and that alignment. You're like, oh, this is like what I'm supposed to be doing. Like, I love this. It feels good.
It's like, I think there are moments in life when you look at what one of my teachers would talk about change points. At what point do you look back and you're like, your life really changed? At that, sitting in that seminar, I would have no idea that I would be doing this right now. But that changed my life. That changed what I was doing, changed my focus, and I think has allowed me to probably steer away from one-on-one patient work, which, I wasn't a very good doctor, I'm afraid. I hate to say it. I'm a much better researcher and analyst and synthesizer. I can do a much better job teaching. I think the patients are much better off not having me as their practitioner. But anyway, it's been an incredible journey, and I'm just, right now, I think we've got over 500,000 blood tests in our software system, which means hopefully that 500,000 functional health reports have been run, that 500,000 patients have had their lives touched. So really, this is about providing you, the practitioner, with a tool that can help make change happen, because we need it. That's the goal, is optimal health worldwide, whatever we can do to do it. And if I'm contributing my little bit to it, then that's good enough for me.
Yeah. Oof. Yeah, for sure. And like the software you were saying, it's like, the software is, I don't know how long I've been using the software now. I think a while, at least 7 or 8 years or something. But yeah, it's been pivotal, because it's not just like, yes, it gives you the functional report, but also the information that you have on there about like the different biomarkers. And it's just like, I still reference it, right? It's like, I still reference it, even though I've been doing it for years. It's like, I still go back to those blood things. I'm like, oh, okay, this is out of optimal range or above or below optimal range. What should I look at in addition to all of the things? It's just super, super awesome. So
I just want to make one thing very clear to people too. It's like, you don't have to use software. I mean, I just happen to have created a tool. If you want to do it manually, like I did for 15 years, absolutely go for it. We've got tools. If you want to come over to my website, download some tracking forms, we've got it for you. So yeah, please don't feel like the only way to be doing this work is through software. It's not.
Yeah, thank you for saying that. I'm a huge fan just like of saving time and energy. And that's what I feel like the software is really, really good at.
Exactly.
All right, so let's talk about some lab stuff. So commonly people tell us that they've had blood testing done by their doctor, often just a basic chem panel screen, CBC, and they're told that everything is normal, but they don't feel normal. I don't know how many times I have heard this, but so many times from clients and patients. And I'm assuming you see that too. So
all the time.
Let's talk about that. What does that mean? Let's talk about standard ranges versus optimal ranges, like good stuff.
I think the difficulty comes from the way that our healthcare, and it's not really healthcare, it's disease management, is handled in the United States and in Western developed countries. The amount of time that people have to spend with someone to try and help them is very minimal. So if you can imagine you've just run a blood test on a patient and the results come back, you don't have the time, the luxury that we do in the type of work that we do to be able to kind of dive deep into what's uncovered by those numbers. So you're really relying on highs and lows, what's high and what's low. And when you really look at how labs work out what something is high and what something is low, it's mathematical. It's not done on health. It's absolutely completely divorced from health. It is a mathematical statistic. So when you look at, let's say, blood glucose readings, so the lab maybe has 30,000 blood glucose tests that comes back. There's a whole wide range of values that come in. They throw out the outliers high and low. And then they look at that subset of numbers and they go, all right, so 2.5% of the population will be considered high and 2.5 will be considered low. That's it. That's what that number means. And so if you're 95%, you fall in the middle of that, you're considered normal. And we know from the work that we do that normal is not optimal, because you can walk around, you can be ambulatory with a lot of numbers that are not very good. And I think it's a real shame. So that's the way that standard range is done. The other thing that really irks me is that, LabCorp, which is the biggest lab in the US along with Quest, they have completely different ranges for some values. I mean, they're similar, but they're different. So my joke is, like, you could be in Boston, Massachusetts, get a nice blood draw in Boston. LabCorp tests your blood there. That vial of blood travels to Los Angeles, and Quest does the testing in Los Angeles. Your blood glucose could be normal in Los Angeles and abnormal and it's the same blood. So that's why we need standardized optimal ranges. And so what we do is we look at, if the range is this broad, we tighten it up a little bit, and we go, there is a subset within that normal range that is considered out of optimal high and low. And it's that little difference that makes such a difference in terms of what you're looking at. So that's the work that we do, is through looking at this lens of optimal range, what we call like a physiological range. If we had a superhuman being here and everything was functionally optimal, all their metabolism, biochemistry, and everything was functioning well, their genes were perfect, my hope is that they would all fall within the optimal range. I haven't seen it yet.
I haven't seen it either, and I think I've run over 1,200 reports myself. So
sure you have. Yeah.
But one thing that I learned from you, going back to like the 30,000 tests, right? That they create this average, then we've got this bell curve average, and like you said, 2.5% on either side. It's like, where are those 30,000 tests coming from? It's coming from an unhealthy population, right? Like you're saying, really, because like the masses are not optimally healthy. So we're basing these averages, these standard ranges on an unhealthy population. And then, of course, as you probably know, there is some influence from the pharmaceutical industries as well, as far as ranges go. And so it's like, we need to have those optimal ranges.
One of the things, having done this work for such a long time, is that you will actually start to see that in some situations, the reference ranges are starting to be influenced by research. And blood glucose is a classic one of those. When I first started, I think the high normal was about 115. Now they've really realized, there is this concept of pre-diabetes. There is a state of physiological dysfunction called pre-diabetes that actually has, blood biomarker changes associated with it. I mean, I would say that that's great, if we can look at pre-diabetes. But the trouble is what do they do about it? Nothing. They don't do anything about it. I mean, if you go look at the American Diabetic Association's dietary recommendations, it's horrifying what they're recommending people. And diet is really one of the main things. Diet and exercise are two of the main things that they're doing in order to keep people away from diabetes. One of my early mentors was a gentleman called Gray Graham, he started Nutritional Therapy Association, and I taught for Gray in my early career. He always talked about this concept called the nightmare of yet. It's like, you don't have diabetes yet. So we're going to wait until you do, and then we'll treat you, because we know exactly what to do. We'll give you drugs, and we'll shoot you up with insulin and all that kind of stuff. Well, I don't want to wait till yet. And so the work that we do is about, how do we identify this dysfunctional state that is early, and how do we use diet, lifestyle, exercise, nutrition, mindfulness, proper sleep, supplementation, to bring you back to a state of optimal wellness before it's too late. We don't want to wait until surgery. I mean, gallbladder is another issue, right? So people have a lot of gallbladder dysfunction. Well, the nightmare of yet is it isn't inflamed enough that we can whip it out, but we'll wait until it is, and then we know what to do. It's like, no, there's a lot we can do for gallbladders before you whip them out. So much. Yeah, I love that you bring that up. It's like, that's where our magic is. It's really helping people prevent the pathology, prevent the lesions. And there's so much that can be done. So that's why functional labs in general are just so helpful in helping us do that. So I know that a lot of these practitioners are going to be familiar with CBC, chem panel stuff. Sure. So let's talk about some things that you commonly see in a CBC that
that might get missed to the untrained eye? And if a practitioner has a patient's or client's CBC in front of them, what are some key things that you could point out to them from a naturopathic or functional perspective?
I think one of the things that we should pay attention to is patterns that we're seeing amongst biomarkers. And that's a lot of the work that I do in my training in the software is built on patterns. A lot of times allopathic physicians, it's a one-stop shop. It's glucose only. It's not glucose and hemoglobin A1C and EAG and fasting insulin and C-peptide. It's just like building up this case. We were talking earlier about how important it is to get more than just one view of anything. And even within the blood world, there are patterns that we look at. So I teach a training that I call sort of the 10 essential blood tests and 10 things that you can kind of pick up from a chemistry screen. I think one of the first things is looking at the ratios and views between the proteins. So the main proteins are albumin and globulin, both of which are created and synthesized within the liver. So anytime something's like the liver is involved, it's like, ding, 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 pay attention, because low albumin levels is an early warning sign of liver dysfunction, and even above and beyond the liver enzymes that we can look at. And there's also kind of like a slight digestive component to it. And digestive analysis is not something that a chemistry screen or a CBC is going to categorically say, oh, you've got this because of this. It's more like it's inferences. And it's like, so things that we can pick up is like digestive dysfunction. The most prevalent I see and have seen is hypochlorhydria or low stomach acid. It's this insidious thing that we see. Oftentimes people are interpreting maybe even some of the symptoms of hypochlorhydria as acid reflux. And it's really not. It's just that your stomach lining has been irritated by long-standing low stomach acid. And it's actually quite important to take a look at. So when you see that, you start to see shifts in some of the globulins and albumins and proteins. And there's some other biomarkers as well that we take a look at. Because stomach acid is essential. When we look at digestion as a north to south process, starts in the brain mostly with sort of this sense of smell or anticipation of food. It triggers salivary. I'm getting it right now. Just so, and then, the digestive system gets triggered to start releasing and secreting stomach acid in anticipation of food. When that doesn't happen, it triggers a whole range of problems downstream. And so really identifying and recognizing that iron and B12 and calcium, a lot of these nutrients need an acidic environment to be released and removed from the food matrix that they're part of. So it's an essential thing to take a look at. So that would be something that's kind of one of the first things I look at is sort of globulins. And then I look at liver enzymes, 3 main liver enzymes, ALT, AST, and GGT. And there's a little rule of thumb that I look at is like, if the AST is higher than the other 2, consider that the problem or area of involvement is actually outside of the liver. Because skeletal muscle, cardiac muscle releases these enzymes as well. In fact, if you have a heart attack or they suspect you've had a myocardial infarction, they will actually look at the ratios between AST and ALT over time to see when you actually had your heart attack, which is pretty interesting. And then if the ALT is higher than the other 2, then probably the area of involvement is actually lying within the liver itself. And if GGT is elevated above the other 2, then it's probably gallbladder. It's just like little things like that, just very quick. You can just run your fingers down and go, oh, wow, GGT is at 38. The other 2 are 16 and 22. Now I'm starting to think, well, maybe that upper right quadrant pain that they're having, maybe that's gallbladder. Or when we start looking at bilirubin levels and things like that. I think another thing that I look at is the CBC really, and this is hard because I think a lot of practitioners, not our practitioners, but, Westernly trained medical practitioners, they just don't have the time to be able to fully analyze a blood test to look at things like anemia. So they're coming to conclusions about an anemia based on just the CBC. And that's kind of why I like running things like ferritin, total iron, doing a full iron panel. It just makes sense because so many women are iron deficient. And if you can start correcting that early, don't wait till it's off the charts deficient. Start early and getting them some good food-based iron. Make a huge difference with energy and being able to get up in the morning without getting dizzy. And it truly can change the quality of life when you start addressing from an earlier stage rather than waiting till something's deficient.
Yeah, I love that you brought that up on the CBC and kind of treating anemia from the CBC alone. And it's like so many people, I feel like practitioners just assume like, oh, it's probably just iron. It's like, you should probably check that before you supplement it. And iron's also like the iron panel is also something I run on men too, because I've seen so many men with hemochromatosis that no one caught before because people don't think to measure iron and ferritin for men. And it's like, come on, guys.
Yeah. I just picked up a little comment here. You know, plant-based iron. I mean, even something like FluoriDx. I don't know if you know FluoriDx, which is a liquid iron supplement. I know some of the companies that we work with have plant-based iron supplies. So you're not just using, you know, those horse pills that they give at the medical doctor's office, which make you horribly
constipation.
Yeah, exactly. So I mean, I think there's a lot that can be gleaned. You know, even looking at alkaline phosphatase levels, if they're starting to drift low, it's like, you know, thinking about zinc, or even albumin levels, starting to think about oxidative stress. I mean, there's just these little, what I call sort of flavors. Obviously, when we start doing more comprehensive panels, then there's more biomarkers that can be more informative, and that sort of thing.
Yeah. And we've only talked about CBC and Chem Panel, and it's like there, you can already start to see, I'm sure as practitioners, how you can use these to start cross-referencing or start investigating other areas that might be imbalanced. And that's why, like we were talking about at the very beginning, it's important to take into account your client or your patient's symptom picture and what they're managing or what they're dealing with on a day-to-day, because that's going to help also guide you. And that's actually one of the cool things I don't think we've talked about, or maybe we weren't planning on talking about, but the NAQ, the Nutritional Assessment Questionnaire, is like super pivotal. I use that with my clients all the time, just to really help figure out based on symptoms. So it's more of like a subjective assessment as opposed to like the labs, which are more of an objective assessment. But it's like bringing those two together is like one of my favorite ways to just really create a more comprehensive approach and more strategy. Yeah.
I was working with NTA kind of when they came up with the NAQ and wrote a book around it. So I'm a big fan of that approach. I think any time that you can put together a questionnaire like that the patient is answering, not just once, but using it multiple times, because ultimately what you're wanting to see is change, right?
Yep.
That's why I love historical reporting in the software. It's like we're looking for change. How is this biomarker changing over time? Because if it's slowly starting to go up, in that moment of time, it's suboptimal, you know, or whatever. It's like, okay, but if you're looking at it over a year or two, you realize, oh my gosh, this is starting to climb up, even if it's a, you know, 1/10 of a point every time. That's important information. So the NAQ is really important for looking at how symptoms change, because, you know, truth be told, patients are experiencing these symptoms. And these symptoms are impacting their lives, like migraine headaches, for instance. If you've had migraines, they're terrible. They can destroy your life.
They're crippling.
So they're crippling. Yeah. So for some people, whether you have a migraine every week or whether you have a migraine a month, it's all terrible. But if you can sit and go, hey, when you first started working with me, you were having a migraine every week. Now you're having them once a month. You're still having them, but that change is really important. Look what change you've made over time. And sometimes, you know, when you've got your face pressed against the wall of a tree, you can't actually see the forest. So, you know, an NAQ is really helpful like that. Yeah.
Yeah. And I love that you bring that up too. Cause like I use the NAQ when I first start working with someone 3 months after and at the end of our program to see that progress, you know, and it's like, you're totally right. Cause I don't know how many of you practitioners can probably relate to this. It's like your clients come back after a few months and they're like, yeah, I don't think I've had any change, or everything's still the same. And you go back and you're like, actually, like you were dealing with this, you know, just a few months ago. And they're like, I was.
Well, what I love about it is they're the ones that are giving you the responses. It's like, you know, I was not sitting there twisting your arm behind your back thinking you know, this was you reported this.
Totally. Yeah. It like really brings things back up and like, and then they're like, oh my gosh, you're right. Like, that's so cool. Awesome. So
can I just bring up a little concept that I kind of talk about a little bit is this concept of what I call gateway testing. Because sometimes the chemistry screen and the CBC, it can give you some really great information. I know you had a Vexer on here before, who obviously is a great provider for blood testing services, but also specialized lab testing as well. And I recognize that blood testing plays a very important role in that first view of what's happening in the body. And there really is a need for further testing or specialized testing. And I was just thinking about one of the patterns that I was looking at is sort of adrenal dysfunction. Now, the chemistry screen isn't great at basically, pinpointing and going, oh, you're in this decompensated phase of whatever, but it can really help by going, gosh, there's adrenal issues going on here. Your potassium levels are off, your sodium levels are off, your DHEA levels are off, your sodium potassium ratio is off. And that's really what I think about as like a gateway to doing further testing. So that would be a great opportunity to do an adrenal stress index, 4 times salivary cortisol with a DHEA, get the salivary cortisol DHEA ratio, get the secretory IgA, rather than jumping into doing those things first. Use the chemistry screen as sort of as what it really is a screen. You can treat presumptively from it, of course, but also you can use the results that you're getting to do further testing. Like if the digestion markers are really coming back strong, do a CDSA or comprehensive digestive stool analysis. Or if the cardiovascular markers are coming back, go do some deeper dive into all of that kind of stuff. So recognizing that it is assessment as it is right now, but it's also leading us to be looking in sort of a deeper direction as well.
Exactly. Yeah. And that's one of the reasons why I love it. It's like, it's great for cross-referencing. It's great for confirmation. It's great for like kind of solidifying your story and your hypothesis of what's happening with your client, which is just like, and as you probably know, it's like, when you build up that clarity and that confidence with your client, you're actually relating what they're dealing with or their symptomology to what we're seeing in the objective data, like the labs. Their follow through is so much higher because they're like, oh, okay, this is all making sense. Okay, well, like, let's do this, And that's
I love that you brought that up. That's sort of the building of the hypothesis concept, because that feeds into what we were talking about earlier, which is, use every available tool that you have. Use the patient story, use the blood, use urine, and build that case so that, yes, when you kind of sit down with them and do your report of findings, and you can tie all of those things together, that's a real skill, which, you're teaching and showing people how to do, but it is incredibly effective.
Yeah. Incredibly effective. Like life-changing for you and your practice and your clients. Amazing. So what are some other biomarkers beyond the CBC and Chem panel that you routinely recommend and look at?
Yeah, it really depends on sort of, I think a lot of it is about what systems or areas of the body that are you interested in. And I think that the NAQ can actually steer a lot of this as well, because if someone's coming back and they've got a lot of blood sugar regulation symptoms and you're seeing that their fasting glucose and EAG and hemoglobin A1C is off, then starting to do some more deeper dive into blood sugar regulation is really important, looking at fasting insulin and C-peptide. The great thing about those two biomarkers is, along with fasting glucose, now you can take advantage of the HOMA2 calculations, which is a group. If people aren't familiar with HOMA2, go over to OptimalDx.com. We've got tons of articles on the HOMA scoring. This was out of the University of Oxford, and they came up with an algorithmic analysis of fasting blood glucose with insulin or C-peptide. So you have to have the fasting glucose, but you can use fasting insulin or C-peptide. And what they're really looking at is how can we use those two biomarkers together to give us a sense of where someone is in the sense of insulin resistance. What is their pancreatic output like? And how sensitive or insensitive are the tissues to the insulin? And it's really valuable. And you get this score called the HOMA2-IR, or insulin resistance score. And even patients that are sort of sub-threshold with their fasting insulin and fasting glucose levels, you can start to see, wow, if we keep this up, you're moving in the direction of insulin resistance, which is the key step on the road to diabetes. So just by adding in fasting insulin or C-peptide, and you've already got your fasting glucose, now a whole world opens up to you in terms of assessment, just one more biomarker. So that's really cool. If I'm looking at inflammation, I can't go wrong with high sensitivity C-reactive protein, and then you're adding homocysteine and fibrinogen. It kind of gives you this window into endothelial dysfunction, which is the early stage of cardiovascular risk in terms of arterial issues. So endothelial dysfunction, you can start getting a little window into that. And we wrote a whole white paper on that over at ODX as well, if you're interested in looking at some of that. I like looking at hormones, especially, I do a lot of work with, working with practitioners around male hormones. Unfortunately, the female hormone side of our software is a little lacking. We're working on that. We recognize that female hormones are very complex. So many variables.
Actually, I like pairing. I like pairing, something like the Dutch blast test with the blood chem, because I feel like that gives a much more complete picture of what's happening as far as female hormones go. Yeah,
I think the Dutch test and the work at Carrie Jones and Precision Analytics and groups like that. Yeah, so the Dutch test is super, super important. But you can get a little window into female hormone dysfunction just by looking at blood. People always ask me, well, why, when saliva or urine is so much more effective, why are you looking at blood? It's like, when you've got a needle in there and a catheter in that vein, let's just collect some more fluid if you can. It's like, the damage has already been done. Let's gather it, because it can be very informative. And it's that earlier point that I was making about, maybe it's not about assessing right now, but it's about giving us a whole big picture view of what's happening within a system, so that you can then do more surgical, specialized testing.
Exactly.
Yeah. What else? Doing like full iron panels. I've got a screen open here. We can just take a look at some of my notes here. Yeah, the homocysteine is super important. So much great stuff that you can get. Oh, the thyroid panel. Why not?
The thyroid panel is
okay,
yes, amazing. Yeah. So
for a lot of practitioners, the only thyroid marker, for a lot of patients, the only thyroid marker they ever get is TSH, which is a real shame. Especially when you're just looking at it through the lens of standard ranges. I think the upper normal is 5.5. So it's a little bit high. But it's like, doing a thyroid panel where we're not just looking at the pituitary output of TSH, thyroid stimulating hormone, which obviously dictates whether or not the body's desiring more thyroid hormone to be secreted and synthesized by the thyroid gland itself. That's a great marker. But, truth be told, it's really primarily used for what they call primary hypothyroidism. You know this. It's like if there is damage or destruction or an issue actually in the thyroid gland itself, TSH is going to be your hormone. For any other type of thyroid stuff, it's not that helpful. So we now need to dive into the actual thyroid hormones themselves, T4, which is released by the thyroid gland, and T3, which is the peripherally converted version. It's peripherally converted into the liver and the kidneys and other tissues into the more metabolically active form. So when you measure those two, you can measure them in total, or you can measure them in free. I like to do both. Now you've gone from just TSH, now you've added 4 more biomarkers. Let me look at reverse T3. We can get the T3, free T3 to free T4 ratio. We can do the reverse, or free T3 to reverse T3 ratio. Now we're starting to get a much clearer picture about what's going on. So that's another example of just by adding in 3, 4, 5 other biomarkers, and typically they panel them together, so they're not super expensive. You can go from just
and the antibodies also.
The antibodies, absolutely, you've got to add those as well. So that would be anti-TPO and TBG, thyroid binding globulin. Now you've gone from, like you said, little keyhole view of the thyroid and its role in metabolism into, like, you've got the whole window. The French doors have been open.
Yes.
So this is another classic example of, like, by just paying attention to what the patient is reporting to you and using your own intelligence, like, I really think thyroid stuff's going on here. I'm not going to do just TSH. I'm going to do a full thyroid panel here.
Yeah.
And the amount of information that becomes available to you is extreme. So I love full thyroid panel and the analysis you can do from that. Just like the blood, vitamin D. I mean, absolutely should be on every. I mean, that should be just on the chem screen. I'm sorry. Even just the role that vitamin D is playing. This should just be added.
Totally. I've really thought like the white blood cell, like the differential has been really helpful too. Like just figuring out like, is this more like a chronic, is there like a chronic thing going on? Is it more acute? Is it viral? Is it bacterial? You know, even with like the eosinophils and basophils and things like that, that can cue you into more digestive stuff. Like there's so much like cool stuff.
Yeah, you can extract a lot of juice out of a CBC. You really can. And like you said, this just by looking at total white blood cell count and then looking at the 5 sub cells that are part of that, like you said, the neutrophils, lymphocytes, monocytes, eosinophils, and basophils, you've got a nice little window into immune function.
So much. Yeah.
And then there's like lymphocyte neutrophil ratios, and then some other things that you can do looking at. I see a lot of low white blood counts, which is, you know, to me is like, how easy is it for this person to mount an immune response if it were to come their way, you know, especially with COVID and all of the other things that we're dealing with. And that's just on the CBC. There's nothing, there's no special sauce there. That just comes with the old CBC. So yeah, it's pretty cool.
Totally.
I like to look at some nutrients too. I like magnesium. I think is a good one to review. And then, you know, serum versus red blood cell. I think they're both very, very important. B12 would be another one that you would probably want to add. And what ends up happening is that your what do they call a Chem 26 or whatever it is slowly becomes 28, 40, 60, and I mean I think
85.
And I actually had my blood drawn the other day, and the guy said I haven't drawn this much blood since I was in the military. I think it was like 15 vials, but
yeah.
But you get a lot of good information from there.
So much. I just had my blood drawn. I figured out how to do it here in Mexico. I was so excited. They did almost everything that I wanted that I have on my panel. Yeah. So pretty cool. But I guess that answers like my next question, which was, do you get routine blood work done?
I do, absolutely. Once a year I get it done.
Yeah. Yep. Same.
And it's interesting. I mean, I'm 52 years old, and it's like I've been getting my blood drawn since I was in my early 30s. So going back and going, wow, you know, talking about historical.
So cool, though.
Just things that we have to pay attention to. You know, when I hit 40, it was like, okay, metabolism starts to kind of work against you. So those
like, how cool is it to actually see that and actually see like, okay, this is where I can start to optimize, or this is where I can start to pivot or refine or kind of put some more focus on or whatever. And it's like, that's the empowerment, right, of having these labs and being able to look at the blood and like see the story that it's telling us. Cause then we don't have to waste our time and energy guessing. We can be like, oh yeah, this makes sense. And this is where I'm going to put my focus. And so it's awesome. Do you have a favorite biomarker or one that you would want everybody to run, something that would be mandatory?
Probably vitamin D, but that's an easy one. I really like DHEA for some reason. I don't know. It's a little window, a little blood glucose window, a little adrenal window. I think it's one of those
catabolic, anabolic.
Yeah, no, absolutely. I think it's one of those hormones that really people don't pay a lot of attention to it. I know, like in sort of what is it called, the adrenal stress index. They just do one value and then they're looking at the ratio with cortisol. But I think in terms of sort of a longevity hormone, I think it's really important. I think it helps to reset that anabolic, catabolic reset in the body. For a lot of people, it's very low. And unfortunately, it is one of those hormones that normal ranges will start to change as you get old. Now, does that mean that the tissues of the body become less needful of it? I don't think so. I think our tissues of our body still are responsive to DHEA. I think the issue is that as we get older, our hormones start to run out of steam and they produce less of the hormone. I remember reading somewhere that maybe even mild arterial sclerosis happening in the adrenal glands could be impacting. If you think about, we get arterial sclerosis in big arteries, but what about small arteries? In the testes, in the ovaries, in the thyroid, in the anywhere where there's a need for blood supply to these high endocrine organs. I don't know. I don't know if that's true or not, but we're trying to find reasons why. At 85 years old, your DHEA output is like 75% what it was when you were in your 30s. Is that normal?
Yeah.
I guess I don't know.
Yeah. Is it optimal, right?
Is it optimal? Right?
Yeah. So we have just like another minute before we dive into Q&A, but I wanted to ask you one more thing. What are 3 things that people can work on that will have the biggest impact on their blood test results?
Sleep, I think.
Sleep.
I'm seeing. I just got an Aura ring for my birthday. I don't know if you know the Aura.
Amazing.
You know it, right?
Oh yeah, for sure. Yeah.
The window it's giving me into sleep is profound, and recognizing that how important sleep is for. We just talked about anabolic repair, right? So the body's repairing itself overnight, and as we get older and older, the repair stuff becomes a little bit more difficult. So I think sleep is really, really important. I would also say that watching your carbohydrate intake, obviously, is very, very important. Making sure that your diet is composed of balanced, plant-based is an approach that I use. I'm not against people eating meat by any stretch of the imagination, but a plant-based diet is, I think, a very healthy one for us. What would be a third? I don't know. What about you? Just throw out one.
I mean, the biggest thing that comes to mind is stress, and it's just like managing, and I hate the word like stress management, right? And I feel like stress management could be something different for every single person. Like it's just as unique and individual, like to you. Maybe that's breath work, maybe it's meditation, maybe it's reading a book, maybe it's walking on the beach, and maybe it's petting your dog. Like but like could be different for everybody, but it's like at least making some time every day to really check in, ground, center, and like kind of recalibrate, because I think it's so easy for us to just be like distracted all the time and like just denying that we have stress, but it has such a huge impact on our lives.
It's funny being on this side looking back at my kids that are in their 20s and realizing, boy, they none of them drink and they don't smoke. They live healthy lifestyles, but their stress levels are high, and they feel like they can keep going. And I'm like, I thought that too.
Yeah.
And my mom was telling me about, you got to watch this and watch that. So, we just did a podcast on stress. We just wrote a white paper on it, and Beth Allen, who does a lot of my research, just did a full workup on just all of the mindfulness and meditation. I use Headspace. I like Headspace. Meditation app.
Headspace is cool.
Just taking 5 minutes just to be quiet. Forest bathing. I used to live in Vermont for 4 years, and we had this beautiful pond out in the middle of nowhere. And we used to, my son was just like, God, I really missed that pond. It's like, that was because we were forest bathing.
Chilling out. Yeah. All right, I'm going to jump into questions. You ready for some questions?
Sure. Hopefully I can answer them.
Let's dive in. Let me here we go. So Chris asks, what could cause elevated B12 in absence of other abnormal labs? Result is 1,612.
Taking B12? I mean, that would be the first thing. That
would be my first guess. Like in a multi, I would have them definitely check their supplements, what they're taking.
I'd have to look that up. I don't know anything off by heart. I think we did actually write, if they want to go over to kb.optimaldx.com, K as in Kate and B as in boy, it's a knowledge base. I think we did answer this question. Beth Allen wrote a response to why B12 levels would be high. So if you do want to go over to kb.optimaldx.com, type in B12, I think we may have answered that question at some point in the time. I can't remember off the top of my head.
Perfect.
I don't think there's a problem running around with a B12 that high. But
the water soluble vitamins.
Yeah.
Laura asks, wow, there are blood markers to show hyperchlorhydria. Which blood labs show that? Okay,
so a little caveat here. They're not showing hyperchlorhydria. What we're looking at is if you start seeing some of these biomarker results, think that a hypochlorhydria could be contributing to the reason why those blood markers are the way they are. So what I look at is, first off, total globulin levels. If they start to be elevated, again, this is, we get asked, can you substantiate this from the research? And it's like one of those things that's hard to find. We dive into the stacks as much as we can. This was actually something that Harry Eidner picked up way back in '96 when I studied with him. And it bears true, because I was doing a lot of the string testing. Do you remember the gastro test, which they don't make anymore? I wish they would. But we were actually directly measuring pH of people's stomach. You basically swallow a piece of string and pull it out, lay it on a white piece of tissue and paint it with pH indicator. And we found substantially that these people that had this particular blood pattern that I'm about to go through, when you looked at their actual stomach pHs, they were all high. They were in sixes, which they shouldn't be. It should be up in the twos. So what we're looking for is increased total globulin. You also might see a shift in the total proteins and albumin levels. You might see your BUN levels start to be a little bit increased, but not enough to be kidney issues, but starting to creep up above 16 for those of us here in the US. Phosphorus levels starting to decrease below 3. And then we're looking at some of these other biomarkers. We talked about earlier how nutrients are affected by stomach acid, and whether or not you have enough stomach acid to be able to break these nutrients free from the food matrix. So we would look at MCV, for instance. MCV above 90 would indicate that there was B12 issues. We know that B12 is an important nutrient in the body, and therefore needs stomach acid on some extent. Calcium levels might be low, below 9.2. Serum iron levels might start to be low. CO2 levels will start to be low. Chloride levels will start to be low. Hydrochloric acid needs chloride. Anion gap levels might start to creep up a little bit, because that's a thiamine marker. So anything above 12. And that anion gap, we're looking at sodium and potassium. And then you subtract from that the chloride and the CO2. A lot of times anion gap is just sodium, and then you subtract the chloride and the CO2. We look at a slightly deeper view of the anion gap by using sodium and potassium there. And then alkaline phosphatase being low. We know that zinc and thiamine are both essential for the synthesis of hydrochloric acid in the stomach. So you can look at zinc levels as well, check for the white spots on the fingernails, see if they have a decreased sense of taste and smell. There are lots of little clues that we can get to zinc deficiency. Are they chronically sick with low immune function? Do they have poor skin healing? These are all signs and symptoms that will be on a questionnaire asking about zinc, because zinc is so important. So zinc and thiamine are two of the most important nutrients for hydrochloric acid. So you start seeing these things. They don't all have to be there. But if you start seeing, and that's where the software, we use an algorithm that actually starts looking at all of these together and starts to quantify them. So if you're starting to see 70, 80% likelihood of probability, it's like, start looking at some other things as well. If you're part of Nutritional Therapy Association or have done some of the health coaching, that they look at some of the Chapman reflexes and things like that you can look at on the body. Just ask questions. How is your digestion? Actually, that's not a very good question. You want to get a little bit more specific than that. But
more detailed.
More detailed. But the NAQ has I think maybe 8 or 9 different questions that we ask around upper GI, just the stomach and digestion, stuff like that.
So good. All right, we've got 8 more minutes to answer
that was a
11 questions. No, it's good. But it actually led into perfectly this next question, which Amy's asking, where can they get access to the NAQ?
Oh, go to OptimalDx.com. We have a resources link. If you go to the resource center, I believe we have handouts and things like that. You can download the NAQ for free.
Yashika says, can you comment on CK outside of cardiac injury?
CK? Well, creatine kinase is actually produced in lots of different tissues. So it's produced in the muscles, it's produced, I think cardiac muscle, I think it's produced in the brain. So you have to start looking at what tissues could be responsible. That's why you can actually do, I think it's isoenzyme fractionations of CK. That will tell you a little bit more. So my rule of thumb is if the actual creatine kinase comes back out of normal range, that's a great opportunity to call up the lab, because the lab will keep a blood supply for, I think, three days. Is that right, Michelle?
Yeah, something like that. Yeah,
something like that. So they do that because they realize that there might be some results that are coming back that you, the practitioner, want to order more testing on. So call up the lab and ask them to do a breakdown of the different fractionations of CK.
Get more specific.
Yeah, you can get more specific on that. In terms, it's not a biomarker that I have a lot of personal experience with, but I do know that it's one of those ones that you can do fractionations of, and that will tell you specifically which tissues are producing it.
Perfect. Thank you. Yoshika has another question here. If you do not see improvement in iron deficiency anemia with treatment, do you look at the gut?
I would look at the gut. Yes, absolutely. I think the gut probably, while you're treating the iron deficiency anemia, take a look at the gut at the same time, because you know that's the reason why, from a naturopathic perspective, it's the very first thing that we look at is gut health. It's the very first series of body questions on the NAQ are all to do with the gut and liver. So absolutely, I think that's essential. I would also look at magnesium and looking at some of those other accessory nutrients that could be out of balance at the same time. Oftentimes, if there's one out of balance, it could be a lot of other ones. Also, look at what types of iron you might be treating that patient with.
Absorption, yeah, for sure.
If that iron deficiency is not going away, I think you also have to consider that there might be a bleed somewhere, or do some further evaluation as to why this person is not getting better.
Yeah, or even chronic infections. Sometimes I've seen.
Yeah.
That as well.
Because bacteria like munch up on iron. They love it.
Yeah.
No, exactly. So there's lots of things that you can look at outside of just that the therapy itself isn't working.
Yep. Perfect. Hugh says, where can I get optimal range information?
To OptimalDx.com. We have a white paper on optimal ranges that we wrote. We have a whole part of our website, a web page that we wrote about the optimal range. So hopefully that will answer some of your questions. We are actually at this point doing like I said earlier, a very deep dive to provide the substantiation behind it, because that's the question that we always get. Like, well, where do your optimal ranges come from? We're like, well, where are the standard ranges coming from? Nobody ever asks that question. Like, we just take it as gospel that the little H and the L means something outside of whatever it means. So I always get a little bit defensive on that front. But yeah, we're working very hard. We're starting to post more into our blog. If you want to keep updates on our blog, you can subscribe to the blog. I think weekly updates on our research blog, and then also our optimal blog as well. I know that we've just posted up a whole load of research on glucose and some of the blood glucose markers, but we are working our way through, I think, 126 biomarkers to at least provide some substantiation as to why we're seeing what we're seeing. And there is a ton of information out there. It's just most people don't have the time to look at it.
Yeah. Amazing. So much good stuff, so many resources. And our Via Summit support, Kara, she's popping some of these links in there for you guys so you can check out like the optimal range page, the resources. Yoshika says, question for either of you. I'm seeing many patients lately with increased ETOH alcohol intake. What do you use to replace ETOH intake?
I'm not quite sure. Like,
I'm
if someone is
not
drinking
entirely sure.
If someone's drinking a lot of alcohol, what do you do to get them to not drink so much alcohol? Is that I don't know.
Yeah, is that your question, Yoshika? Could you clarify what that question is, and we'll try and answer it for you. And then Hugh says, what labs do you recommend if patients are financially constrained?
Oh boy. I think that you could still just do a very basic CMP 14, I believe, is what they're at right now, and a CBC. I did a presentation for Rupa Health. I know you just did one with Avexia. I would contact Avexia and I would say, what is the cost for doing a CBC? And you want to do it with differential so that they are actually giving you those white blood cells. And
which is probably on like $10, literally, like
if that,
like $10 or $12.
Okay.
Yeah, it's
again. I know that you just
cheap.
had what is this? Access Medical, their basic metabolic panel, which has glucose, BUN, creatinine, sodium, potassium, chloride, CO2, calcium, and GFR, is $2.
Wow. Yeah. Like
$2.
there are definitely some, yeah.
Absolutely. So really work. I mean, I love Avexia. I've been working with Kevin for, since 2006. I know him personally and I've stayed at his house. And Avexia is an incredible company. They will give you the very, very best pricing available. Rupa Health is another company that I'm familiar with, and they too are providing really amazing pricing. So if a patient is struggling, Avexia may even have scholarships. I don't know. Some of these companies do have a sort of a pool of money that they put aside. I don't know if that's the case or not, but definitely just doing a basic metabolic panel and CBC, and then just get a copy of my book or go to the website. There's still a lot of incredible information you can get out of that. Actually, we'll probably end up redoing these 2 webinars that I've done in the past. One is Hidden Intelligence from the CBC and the CMP. The other one is the 10 most important additional blood tests. I should probably redo those and get them up on the website with this valuable information that you can then use to extract functional data from just the very basic health CMPs and CBCs.
Amazing. So good. Okay, one last question. We've got 1 minute. Yetta says, have you seen an association between lower white blood cells and eating a vegan diet?
Yes.
Yeah.
I don't know why, but we see it all the time. My wife's a vegan, and she probably will hate me saying this, but she has a very, very low white count. It's been like that for years, and she's been a vegan for years. It is one of those things I remember. And again, I don't know why. I don't know why that would be, but it is definitely something that I have seen a lot. And it's actually the very first question that I ask if I see someone with an unexplained low white count. I'm talking about in the 3s. If you're looking at it in the 2s, there might be some other issues going on, sort of immune deficiency type of issues. But yeah, it is very common, and I think they are perfectly healthy. I don't think there's any need for stimulating white blood cell production. It's probably just their natural state of being. And she hasn't caught COVID, and I've had COVID twice. So she's living with me both of those times. So,
So fascinating. Thank you so much. You have been pivotal in my own practice, beyond words. And so thank you.
Well, I just appreciate
the work that you're doing.
Yeah, you too. And I think any opportunity that we have to create successful businesses is absolutely paramount. And I remember one of my mentors, I'll finish on this, one of my mentors, when we were standing up about to go and graduate, he said, you are graduating as naturopathic physicians, but ultimately you're going to have to be business people, because if you're not making money and able to support yourself and your family, you're not going to do anybody any good. So whatever, Michelle, whatever you're teaching, listen to her, because she's built a very successful practice and can help you, because you're needed in the world. And whatever we can do, or whatever I can do to support you in that goal, come over to OptimalDx. We're here for you. So thanks. Appreciate it.
Thanks. You're going to make me cry. Anyway. All right. Thank you so much, Dr. Weatherby. I will chat with you soon. Bye. Oh, so good. Thank you, everybody. I hope that was informative and inspiring and encouraging. Functional blood chemistry analysis, like I said, has been just a total game changer for my practice. And it was really the gateway for me to get into functional blood chemistry analysis. All right, that's a wrap for today. If you want the exact breakdown of how I help practitioners go from their first 5K to consistent 50K months with just 2 offers, 10 hours per week, and an audience of less than 500 people, be sure to click the link in the podcast description or head to wealthywoman.co/breakdown. To make sure you don't miss an episode, be sure to subscribe. And for daily online practice insights, follow me on Instagram at wealthywoman.co. Let's create your life of wealth, full of abundance, purpose, health, wealth, and joy.